Welcome to this case-based clinical review on developmental dysplasia of the hip, part of the musculoskeletal system series from Pediatric Case Review. This lecture is designed for general pediatric physicians and covers 15 clinical cases spanning physical examination, diagnostic imaging, and treatment protocols. Let us begin. Case 1, covering clinical presentation with asymmetric skin folds. A 3-week-old female infant is seen during a routine well-child visit. The right thigh crease appears deeper than the left, and the right lower limb appears slightly shorter when both hips are flexed at 90 degrees. There is no history of breech delivery and no family history of hip problems. What is the most likely underlying musculoskeletal condition? Option A, congenital muscular torticollis. Option B, metatarsus adductus. Option C, developmental dysplasia of the hip. Option D, leg calf Pertus disease. The correct answer is C, developmental dysplasia of the hip. Asymmetric skin folds are early warning signs of this condition. Unequal thigh creases suggest hip positioning abnormalities, and limb length discrepancy indicates acetabular displacement. These findings are most reliable in infants under 6 months of age. The key clinical pearl is to always examine for asymmetric gluteal folds, unequal leg lengths when hips are flexed at 90 degrees, and limited hip abduction. Early detection prevents long-term complications. Case 2, covering limited hip abduction. A 4-month-old male infant is brought in for developmental delay evaluation. The mother reports the child resists abduction of his left leg. On physical examination, hip abduction is limited to 30 degrees on the left side, but a normal 60 degrees on the right. The infant is otherwise healthy with no neurological deficits. What is the most appropriate next step in management? Option A, refer to neurology for possible cerebral palsy. Option B, order magnetic resonance imaging of the pelvis immediately. Option C, reassure parents and schedule routine follow-up. Option D, perform hip ultrasound or radiograph. The correct answer is D, perform hip ultrasound or radiograph. Limited hip abduction is a highly sensitive sign of developmental dysplasia of the hip in infants older than 3 months. At 4 months of age, the Barlow and Ortolani physical examination maneuvers become less reliable due to developing soft tissue contractures. Imaging provides definitive assessment of hip joint anatomy and acetabular development. Ultrasound is ideal for infants under 6 months, while plain radiographs become reliable after femoral head ossification at 4 to 6 months of age. Case 3, covering neonatal instability assessment. A 2-week-old newborn girl is seen during a routine well-child examination. During hip assessment, the examiner flexes both hips to 90 degrees and adducts the legs toward the midline. Gentle posterior pressure applied to the greater trochanters produces a distinct palpable clunk sensation. There is no family history of hip problems and delivery was normal. What specific physical examination maneuver and finding is being described? Option A, positive Galizzi sign indicating limb length discrepancy. Option B, positive Barlow maneuver demonstrating hip instability. Option C, positive Klizik sign showing femoral head displacement. Option D, positive Trendelenburg test indicating hip abductor weakness. The correct answer is B, positive Barlow maneuver demonstrating hip instability. The Barlow maneuver identifies hips that can be pushed out of the acetabulum with gentle posterior pressure. The technique requires the patient supine with hips flexed to 90 degrees, the examiner's thumbs on the inner thighs and index fingers on the greater trochanters. Then gentle posterior pressure is applied while adducting the hip. A positive test produces a palpable clunk as the femoral head dislocates posteriorly. This test is most reliable in infants under 3 months of age. A positive Barlow test indicates hip instability requiring immediate orthopedic referral. After 3 months, soft tissue contractures may prevent dislocation despite underlying dysplasia. Case 4, covering reducibility assessment. A 3-month-old boy is referred after a positive screening test was documented at birth. At follow-up, the examiner flexes both hips to 90 degrees, applies gentle anterior pressure on the greater trochanters, and slowly abducts the hips. A distinct clunk is felt as the femoral head relocates into the acetabulum. What is the most accurate interpretation of this finding? Option A, normal hip stability with physiologic clicking. Option B, irreducible hip dislocation requiring surgery. Option C, positive Ortolani sign indicating reducible dislocation. Option D, positive Galizzi sign showing limb length discrepancy. The correct answer is C, positive Ortolani sign indicating a reducible dislocation. The Ortolani test assesses reduction of a dislocated hip. The tactile clunk during hip abduction confirms successful reduction of the femoral head into the acetabulum. This test is most reliable in infants under 3 months of age. It is important to distinguish a clunk, which is pathological and represents hip dislocation or reduction, from a click, which is benign and represents ligament snapping. The clinical pearl is to always perform the ortolani immediately after the Barlow test to assess reducibility. The test becomes less reliable after 3 months due to soft tissue contractures. Case 5, covering anatomical deficits and pathophysiology. A newborn female infant is born via cesarean section following frank breech presentation at 38 weeks. Physical examination reveals hip instability on the left side with positive Barlow and ortolani maneuvers bilaterally. What is the primary prenatal anatomical factor that contributes to mechanical instability in developmental dysplasia of the hip? Option A, excessive femoral anteversion during development. Option B, delayed ossification of the femoral head epiphysis. Option C, underdevelopment of the anterolateral acetabulum. Option D, hyperextension contracture of the hip joint capsule. The correct answer is C, underdevelopment of the anterolateral acetabulum. Developmental dysplasia of the hip is primarily a failure of acetabular development. A shallow acetabular roof provides inadequate femoral head coverage, and anterolateral acetabular deficiency is the primary structural problem. Secondary pathological changes then develop from mechanical instability and include labral inversion and thickening, ligamentum teres elongation, hip capsule hourglass deformity, and limbus formation from chronic pressure. Progressive deformation occurs without early intervention, which is why timely diagnosis is critical. Case 6, covering environmental risk factors and pathophysiology. A 2-day-old female infant is born via cesarean section following prolonged labor with decreased fetal movement noted on monitoring. Physical examination reveals generalized joint laxity and limited hip abduction bilaterally. The mother reports significantly reduced fetal kicks during the 3rd trimester. Which prenatal environmental condition is most closely associated with restricted fetal movement and increased risk of developmental dysplasia of the hip? Option A, maternal gestational diabetes. Option B, oligohydramnios, meaning decreased amniotic fluid. Option C, maternal hypertension. Option D, multiple gestation pregnancy. The correct answer is B, oligohydramnios. Reduced amniotic fluid restricts fetal movement, and frank breech positioning forces the hips into adduction and extension. Mechanical constraint stretches the posterior hip capsule and leads to capsular laxity and impaired acetabular development. Other recognized risk factors include female gender with a 6-to-1 ratio compared to males, firstborn status, family history of the condition, and certain ethnic populations. The clinical pearl is that oligohydramnios combined with breech presentation represents the highest risk combination for developmental dysplasia of the hip. Case 7, covering hip ultrasound classification using the graph system. A 5-week-old female infant undergoes hip ultrasound screening. The findings reveal an alpha angle of 52 degrees and a beta angle of 65 degrees. The infant is 5 weeks old. According to the graph classification system, how should this hip be classified? Option A, Type 1, normal hip. Option B, Type 2C, critical dysplasia. Option C, Type 3, dysentered hip. Option D, Type 2A, physiologically immature. The correct answer is D, graph Type 2A, physiologically immature. Graph Type 2A represents delayed ossification in infants under 3 months of age. An alpha angle of 50 to 59 degrees with a beta angle of 55 to 77 degrees indicates an immature but developing hip. Most Type 2A hips normalize spontaneously by 3 months with proper development. If the alpha angle remains below 60 degrees at 13 weeks, progression to Type 2B requires intervention. Management involves close monitoring with serial ultrasounds every 4 to 6 weeks. Treatment is indicated only if there is no improvement by 3 to 4 months of age. Age-dependent interpretation is crucial when applying the graph classification system. Case 8, covering radiographic lines in investigations. A 7-month-old infant presents for routine follow-up examination. X-ray shows a disrupted arc between the femoral neck and the obturator foramen. Which specific radiographic line is abnormal in this case? Option A, Shannon's line. Option B, Hilgen-Rayner's line. Option C, Perkins' line. Option D, Klein's line. The correct answer is A, Shenton's line. Shenton's line is a smooth, continuous arc formed between the inferior border of the femoral neck and the superior margin of the obturator foramen. A disrupted Shenton's line indicates hip subluxation or dislocation and is crucial for detecting hip displacement in infants older than 6 months. The combination of a disrupted Shannon's line and an increased acetabular index confirms the diagnosis. Other important radiographic landmarks include Hilgenrainer's line, which is a horizontal line connecting the triradiate cartilages, and Perkins' line, which is a vertical line through the lateral acetabular edge. These lines together help assess acetabular development and femoral head position. Case 9, covering acetabular morphology in investigations. A 7-month-old infant presents for routine follow-up after concerns about hip development. Pelvic radiograph reveals an acetabular index measuring 32 degrees on the affected side. The child is ambulatory and shows no obvious limping. Parents report no family history of hip problems. What is the most likely clinical significance of this radiographic finding in a patient older than 6 months? Option A, normal developmental variant requiring no follow-up. Option B, acetabular dysplasia requiring orthopedic evaluation. Option C, measurement error due to patient positioning. Option D, early sign of Legg-Calvé-Pertus disease. The correct answer is B, acetabular dysplasia requiring orthopedic evaluation. An acetabular index greater than 25 degrees indicates a shallow acetabular roof. The normal acetabular index is below 25 degrees in children older than 6 months. A dysplastic acetabular index above 25 degrees suggests inadequate femoral head coverage. Progressive measurements are used to guide treatment decisions, and the acetabular index is combined with Shenton's line assessment for complete evaluation. The clinical pearl is that an acetabular index greater than 30 degrees often requires surgical intervention. Acetabular index measurement becomes more reliable and meaningful after 6 months of age. Case 10, covering first-line management and treatment. A 2-month-old female infant presents with a reducible dislocated right hip diagnosed through ultrasound screening. She was born at full term via normal vaginal delivery. Physical examination reveals a positive Ortolani sign with successful reduction. The hip is stable when reduced and shows good range of motion. What is the most appropriate initial treatment device for this patient? Option A, rigid abduction orthosis. Option B, spica cast immobilization. Option C, Pavlik harness. Option D, immediate surgical intervention. The correct answer is C, the Pavlik harness. The Pavlik harness is the gold standard for reducible developmental dysplasia of the hip in infants under 6 months of age. It maintains hip flexion of 100 to 110 degrees and gentle abduction, allows controlled movement while preventing dislocation, and is worn 23 hours daily for 6 to 12 weeks. Critical success factors include starting before 6 months of age, ensuring the hip is reducible before application, monitoring with serial ultrasounds, and discontinuing if there is no improvement after 3 to 4 weeks. Contraindications include irreducible hips, teratologic dislocations, and age over 6 months. Case 11, covering management of Pavlik harness failure. A 5-month-old female infant had Pavlik harness therapy initiated at 6 weeks of age. After 4 weeks of continuous harness, we're at 23 hours per day with excellent parental compliance. Follow-up ultrasound shows persistent hip dislocation. The hip remains unstable on Ortolani and Barlow testing. What is the most appropriate next step in management? Option A, continue Pavlik harness for additional 4 weeks with closer monitoring. Option B, switch to a rigid abduction orthosis such as a von Rosen splint. Option C, begin intensive physical therapy and range of motion exercises. Option D, transition to closed reduction under general anesthesia. The correct answer is D, transition to closed reduction under general anesthesia. If the Pavlik harness fails to achieve reduction within 3 to 4 weeks, treatment should be abandoned to prevent acetabular damage, which is called Pavlik disease. At 6 to 18 months of age, closed reduction under general anesthesia is the next line intervention. The critical point is that prolonged harness use beyond 4 weeks in a failing case can cause posterior acetabular wall erosion. The goal is to achieve concentric reduction before soft tissue contractures become fixed. Early recognition of harness failure prevents complications and optimizes long-term outcomes. Case 12, covering intraoperative assessment during treatment. A 14-month-old girl with developmental dysplasia of the hip undergoes closed reduction under general anesthesia. A post-reduction arthrogram is performed to assess hip stability. The contrast injection shows 8 millimeters of medial contrast pooling between the femoral head and the acetabular floor. What is the primary concern regarding this arthrogram finding? Option A, risk of avascular necrosis. Option B, successful concentric reduction. Option C, need for capsular repair. Option D, indication for spica casting. The correct answer is A. Risk of avascular necrosis. Medial contrast pooling greater than 7 mm indicates an unstable reduction and a high risk of avascular necrosis. The target for a stable reduction is less than 5 mm of medial pooling. The mechanism of injury involves compression of the medial femoral circumflex artery, which is the primary blood supply to the femoral head. Vascular compromise occurs during excessive abduction, so maintaining safe abduction angles during reduction is essential. Post-reduction computed tomography can confirm concentric reduction and assess for vascular compromise. Case 13, covering vascular compromise as a treatment-related complication. A 5-month-old female infant was previously treated for developmental dysplasia of the hip with a Pavlik harness. At follow-up, recent radiographs reveal fragmentation of the femoral head ossification center. Parents report the child has been more irritable during diaper changes. What is the most likely complication resulting from treatment? Option A, osteomyelitis of the femoral head. Option B, avascular necrosis of the femoral head. Option C, developmental coxavara. Option D, acetabular retroversion. The correct answer is B, avascular necrosis of the femoral head. Avascular necrosis is the most serious complication of developmental dysplasia of the hip treatment. It occurs when excessive hip abduction beyond 60 degrees compresses the medial femoral circumflex artery, causing ischemia of the femoral head ossification center. It is often linked to improper Pavlik harness positioning. Radiographic signs include delayed appearance of the ossification center, fragmentation of the femoral head, broadening and flattening of the femoral neck, and irregular bone density patterns. Prevention strategies include maintaining hip abduction below 60 degrees in the harness, regular ultrasound monitoring, and discontinuing the harness if reduction fails after 3 to 4 weeks. Case 14, covering acetabular erosion as a complication. A 6-month-old female infant was treated with a Pavlik harness for developmental dysplasia of the hip over 8 weeks. The hip remained dislocated despite prolonged harness use. Follow-up imaging shows erosion of the iliac bone superior to the acetabulum and loss of posterior acetabular roof architecture. What is the most likely diagnosis for this radiographic finding? Option A, septic arthritis with bone destruction. Option B, osteosarcoma of the pelvis. Option C, Pavlik disease, which is acetabular erosion. Option D, osteoporosis with pathological fracture. The correct answer is C, Pavlik disease. Pavlik disease is a rare but serious complication resulting from prolonged positioning of a dislocated hip in flexion and abduction within the Pavlik harness. Chronic pressure from the unreduced femoral head causes erosion of the posterior acetabular wall and iliac bone. This occurs specifically when the harness fails to achieve reduction after 3 to 4 weeks of treatment. Early monitoring and timely discontinuation of the harness is the key to preventing this complication. Severe cases may require pelvic osteotomy reconstruction. The critical principle is never to continue the Pavlik harness beyond 4 weeks if reduction has not been achieved. Before we conclude, I want to invite you to join our Patreon community for Pediatric Case Review. As a member, you get access to all videos organized by system, covering musculoskeletal, respiratory, neurology, and more. You can also download high-resolution slides to study anytime at your own pace, and access a growing library of practice multiple-choice questions and case reviews to master clinical decision-making. If you are ready to join, comment below this post, and we will message you directly with all subscription details. And that brings us to the end of this case-based review on developmental dysplasia of the hip. Let us recap the essential clinical pearls. Early detection saves hips. Screen all newborns with Barlow and Ortolani tests. Use ultrasound before 6 months and X-rays after 6 months for optimal imaging. Pavlik harness success requires proper positioning and early intervention. Failed harness treatment needs prompt surgical referral to prevent complications, including Pavlik disease and avascular necrosis. Please follow Pediatric Case Review for more evidence-based, case-driven content covering all pediatric systems. If you have questions about developmental dysplasia of the hip management, drop them in the comments below. Thank you for joining us. Your expertise grows with every case.